Carl Ellison has been with Indian Minority Health Coalition for many, many years, and he is now the CEO, leading us into the next future of strategic initiatives to change how health equity is done in the state. If we look at our statistics in the state of Indiana, we are traditionally at the bottom 5 of the 50. That's not a thing to be proud of. But change at the bottom is absolutely transformative. And so when you're at the bottom leading, that's when the rest of the nation takes notice. And it's through the eloquence of Mr. Carl Ellison in being able to share in both DC, our state legislature, in the committees that we are not a part of, but what we push through the doors to be at the table in, and the committees that we are invited to, that Mr. Ellison has really showcased representation from all across the state with voices that succinctly are both intelligent, data-driven, informed, and that we are proud that they represent us. And we'll hear from many of those leaders here later today as they share change in state public health policy that is driving health equity forward on an advocacy level. That introduction pales in comparison to the work that Mr. Ellison has done, and I yield the floor to Carl for a wonderful update on the Governor's Public Health Commission report.
Good afternoon, and thank you, Sonny, for that, I don't know what it's deserved, but that great commentary about me and my career. And also, I want to thank Antoinette and all of you involved in sponsoring this event. Because over time, one thing I've observed is that we don't really have enough events that really focus on minority health from a strategic point of view and from a point of view of connecting all of our knowledge. So events like today are always special, and I'm happy and proud to be part of it. Likewise, when I was appointed to be on the Governor's Public Health Commission, which produced this 107-page report, I was actually pretty thrilled because, as Sonny pointed out, often we don't get to be at the table. We just get to see the results of what comes from the table. So I decided today that I'll walk through some of the actual report material. And your takeaway from today is the last slide has the website address to be able to get the report. So my ask of you today is actually read this report. It has some pretty interesting information that will be part of the legislative strategies that are coming up. Now, let me just say, next slide please, that the commission itself, there were 15 of us, and we spent a year developing this report. I must say, among the things I've been on, this one was actually pretty faithful. Almost everybody was at every meeting. And typically we met at the state library from 2 to 4 or 3 to 5, so 2-hour meetings once a month with reading material before and after as we went about our task. We were blessed to be led by Senator Luke Kinley, who was in the legislature. You may know him as having chaired the Senate Finance Committee, and also Dr. Judy Monroe, who's now the CDC Foundation exec. But Judy was our state health commissioner a few commissioners back, and she would travel from Atlanta each month to come to our meetings, although because of COVID times, the meetings were always in person, but you could always attend virtually as well. And then we had oh, okay. I guess I got to really hug the mic better to see memory back. Thank you to that. But I'm saying, so we also had a former congressman, as well as people like Dean Paul Harrison of the Fairbanks School of Public Health. And then we had local public health officials, we had local elected officials, and we had representatives of several organizations,
the Indiana Hospital Association, the Indiana Rural Health Association, the Indiana Public Health Association, and the Indiana Minority Health Coalition. So it's a very, very diverse group. Next slide, please. So what we're asked to do, and these are actual pages from the report, but what we're asked to do as a commission, our charge was to analyze ways to improve public health in Indiana, address the funding challenge to do that. It's written in the report that we are to promote health equity. I'll read all those 107 pages, you'll have a hard time finding how we say we would do that. So there is an underlying presumption that if you improve health overall, you get greater health equity. But be it as it's may, it is actually a part of our charge. And then we were to essentially identify ways to make local health departments more sustainable and ways in which we can better prepare the state for future public health emergencies. Because as you know, the COVID crisis demonstrated gaps in our public health system that affected our ability to reach and serve people. Next slide, please. So, for context purposes, what the commission did was sort of identify the current state. And really that one little box up there in yellow that you may have a hard time seeing kind of says it all. It essentially indicates that between 2010 and the present, in Indiana, we have lost, our life expectancy has gone down. Gone down from 77.5 years on average to 77 years. Now, that's not bad compared to the nation. The national average for life expectancy is 78.3 years. So Indiana is 2 years below the national average for life expectancy, which would indicate we're not a very healthy state. It indicates a lot of reasons why we're at the bottom. Most of the health measures, it shows up in how long people get to live. Now, if you think that's alarming, you also need to know that if you look at Indiana County and say which one has the best life expectancy versus the worst, the difference is 9 years. 9 years difference depending on where you live in the state in terms of life expectancy. Now, we in the commission report didn't go and look at race ethnic populations, but we did, particularly as we know because of COVID, most of the impact of this life expectancy shortage falls on populations of color. So the commission's not wanting to do our work at a time when the state itself is losing ground nationally. And so as we got somebody's actually calling now. Oh, that's the wife. Oh, that's sweetheart, I'm doing a presentation out You who've been married know the rule of thumb. You don't ignore the wife. What you doing? You gotta do that. Anyway, she apologized. She forgot I had this task at this time. So again, just for context purposes, so Indiana, compared to the rest of the nation, we're not doing so well. And akin to this point that parts of the state have 8 years less life expectancy than others, that correlates with what we know in terms of research already done here in Marion County and other places. You know, the most salient one is if you take life expectancy of Carmel and go down Holman Trail to downtown, the closer you get to downtown, the less life expectancy exists. And so disparities, not just for race ethnic populations, but disparities period, are realities within Indiana's public health system. So next slide. So as a commission title of work, we looked at governance and infrastructure. And again, there are a lot of words up there, but the summary of those words is that we spent some time looking at local health board appointments. And this is particularly of interest to me because we don't really know. We don't have a census of who on local health boards. We don't really know precisely. Do minorities represent their share in local health policy on health boards? And so we had some language in the recommendations that deals with community representation. And we, in fact, in this example here, we try to make sure that even in most of the counties under 200,000 people, that the mayor of the largest community would have an appointment on board, because in many cases, we would have a better shot at making sure that person appoints a minority to the board if they otherwise didn't fit. As you may or may not know, health boards are by law intended to have certain skill sets. So you typically will have doctors, you may have some chiropractors, you may even have some veterinarians. But it's not to say you have to have anybody that's raised ethnically from the community on that board. So this is a device, so to speak, that may lead to a statutory change to make it, if you will, easier to ensure we have populations of color on local health boards. Then we also looked at the fact that many local health departments have difficulty getting a health officer, because in smaller communities, the health officer often is retired, may not have malpractice coverage, and frankly, may not have anything to do with it. So one of the things that we're proposing is that we change the law to allow an advanced nurse practitioner, perhaps a physician assistant, be the health officer, but have some oversight at the state level, particularly for those clinical services that health departments are encouraged to deliver more, be it immunizations, whatever the case may be. And this, of course, will be controversial in the session, because typically the doctors don't want you infringing on their area, although in this case, from a public health standpoint, we think it's the commission thought it's absolutely necessary. And then there's also in the report the notion of some level of regionalization. Services like epidemiology, perhaps grant funding, could be done at a regional level versus assuming every county can do its own thing. So from a government standpoint, those are some of the primary things we looked at. But next slide is the money slide, and that's funding. Yeah, that's that slide. So with respect to funding, the issue that the commission raised, at least I raised, was how aspirational should the state be? I mean, we're near the bottom of public health funding, so should we take some action to get closer to the top? Now, you can't see that circle very well, and I presume these slides are going to be shared with you after the conference. But just look at that one up on top. And if you look at that slide, what it says is our public health funding for the Department of Health in the current budget largely comes from the federal government, 75%, and from the tobacco settlement. Together, those like 88% of total funding. Now, you need to know historically that the tobacco settlement dollars really support most of minority health. Supports minority health initiatives, supports community health centers. You know, without the tobacco settlement money, thank God Bill Crawford and others made sure we got some set-asides out of, public health for race ethnic population in the state would be anemic. And in fact, the most important thing from this slide is note that only 3% of the general fund goes to the Department of Health. And this is happening in a state that has more than $6 billion surplus. So minority health and really public health has not been a state priority. Because if you want to know what's a priority for any organization you deal with, you look at the budget. It's in the budget, and it reflects an organization's commitment to something. But if you look at our state budget, we don't really have the state itself giving substantial commitment to public health. And we have, again, the Department of Health has relied on federal funds and federal restrictions, and then the tobacco settlement helps, but only 3% of the current Department of Health budget comes out of the general fund. Again, I remind you, we're in a state with a budget surplus of over $6 billion. So, from a pension standpoint, the issue became, well, if we need more for public health, how should we shoot? And my thing was, what if we want to fund the top 10 and figure out how much that would cost? Well, we settled on getting to the midpoint. So the recommendation is that we increase public health funding from $55 per person to $91 per person, which is the national average. That would mean that the legislature will need to appropriate additional $243 to $257 billion during the next budget session that will arise. And the presumption is that we will need that budget increase permanently. So this is not one time, this is built into the budget baseline on a go-forward basis. Now, remember though that these are just recommendations, and the reason I want you to read this report and get to know it is that during the next session of the legislature, we're going to really fight. We have to go in and fight not only for this money, but also fight for how the money is allocated, because the commission didn't really make any recommendation as to how you address all of the public health needs with this money. But as I can tell you that whether it's the need for more school nurses, or whether it's more paramedics, you know, in this state, over the last 10 years, we've had an absolute decrease in the number of paramedics that can come to your house and call 911, but we've had a dramatic increase in population. So if you're in some of these rural areas, you call 911, you don't get a response, you don't get one right away. And so I asked our Homeland Security people, I said, well, is this trend making the state less safe? And the answer was yes. I mean, it was yes. So our needs are so vast that even $257 million may not be able to address all of them. Next slide. Okay, well, that's the one where it talks about the $55 is what we now spend versus $80.91. Next slide after that, please. We also address among 6 areas, and I'm only touching on 3, workforce. And as you know, workforce is an issue that's on everybody's plate. And essentially, the recommendations had to do with trying to address known shortages and shortages that will increase. For example, the Indiana Hospital Association estimates that it will take 2 years plus just to get the hospital workforce back to where it was pre-COVID. And as you may know, whether it's home care services, whether it's hospitals in the whole health staffing area, there's a very, very critical shortage. And so so we spent some time around the size and the shortage that exists. And you may or may not be surprised, there's a whole lot of data we don't know. I mean, there's just not enough information to help the state precisely know how to go. And so there are a number of recommendations around the proper commissions, there are recommendations around trying to address the shortage through additional incentives, like expanding really the, if you will, the assistance for those education loans, that expanding the loan forgiveness programs, just among others. So workforce will be a big, big issue. It's part of the report deliberately, but it's a big issue that will cut across all agencies and will be a major issue in the legislative session. So you might want to read the report for that matter as well. Next slide. Okay, and so we also looked at clinical data integration and also child and adolescent health. And in those areas, you know, we had the usual findings. Like for years it's been, in every school, you need one school nurse for every 750 students. Been that recommendation for years. I don't think there are any other school systems that meet that criteria. And so, as we looked at child and adolescent area, we had recommendations in that regard, but most of them are intended to address deficits that would better position the state to be able to meet its priority population needs through a more coordinated, more unified, more defined local health system. And I guess I'll kind of say in conclusion, if we get that 240 to 57 million, the intention is that all of that money would flow through a county. So if you're a county with multiple local health departments, you would have to have an agreement, but money only goes through one pipe, not multiple pipes, because it would be tied to an agreement to meet those minimum standards that we've talked about, and we tied to an agreement to lock in local dollars. So you don't get to supplant. So this money is not intended to allow you to now shift more to pay roads or whatever. If you're a local body, you've got to commit to maintain your dollars, to get these dollars and do it all at the county level. So it was, it's a lot of work. It was a joy to work on this process, but to be able to summarize it all in 10, 15 minutes, as you can see, is extraordinarily difficult. So I do encourage you to go to this website, download the report, read the report, and then if you have some observations, call me. Because, again, the report is just a recommendation to the governor. When we get into the legislative war, that $257 million number could become 140 or it could become 340. We don't know, but we do know, like anything else, you've got battle for if you want to ultimately have to become available to meet the needs of public health in the community. I'll just say in conclusion that Indiana hadn't really looked at public health for more than 30 years. So this is the first time in a long time we took a fresh look. And in all of the recommendations within the report, and all the language in the report was unanimously adopted by all the commissioners. So this has a pretty broad collective view that this needs to be a starting point for the state. But now our task is to see if we can translate this into real changes in statute, changes in the budget process, and changes that will commit the state financially out of its own resources to better public health for its people. Thank you very much.